to be looking at the concept of human development. We're still in Unit 1. So human development, you see, I'm about to share the screen so you can see the concept analysis diagram of human development. So let me go ahead and do that. So human development, the sequence of biophysical, psychosocial, and cognitive developmental changes over the human lifespan. Human development is very complex. And this is the one where I say, you have to know what's normal in order to recognize what is abnormal. So knowing normalcy in human development is the key. And I do have a really nice, let's see, and under the modules, I have a nice form, and I certainly don't expect you to memorize all of this, but I do want you to look at this and just get an understanding of what's normal at what age. Now, when I'm talking about human growth and development, I love Erikson's psychosocial theory. And I do have a video provided for y'all regarding his theory that I would like for y'all to watch and listen to, because I'm a big fan of Erikson. Hold on, let me get this back up for you. Okay, so the first thing I'm going to talk about is developmental delay. And this is going to be coming from your maternity book, chapter 54. Just trying to make sure this camera's right. It's tough. So anyway, and just start looking under the section, intellectual and developmental disorders. So this talks about the prevalence of ID, which is intellectual disorders, and DD, which is developmental delay. That's what those two things are talking about, continues to rise. Children who have intellectual or developmental disorders experience genetic or external influence that may limit their abilities. However, these potential limits will be minimized or maximized by their interaction with their environment. And here's the important part. Many intellectual or developmental disorders will respond to early and intensive intervention and close attention. In other words, the earlier that we recognize there's a problem and can intervene, the better the outcome is going to be for this kid. Then it gives you a little thing here of the Developmental Disability and the Americans with Disability Act. And I did just want to mention a couple of things from this. And this is includes autism spectrum disorder, which we're going to discuss individually here in just a minute. But intellectual disability or developmental delay is what we used to call people that are slow, maybe just not quite right. They're a little slow. Just to give you kind of some context on what we're talking about here. So this bill they passed with adding the developmental disability to the ADA Act really impacted the school system. And you'll see it says every disabled child must have a written individualized education plan that outlines specialized instruction and services the public school system will provide. We are trying to make everybody feel very included in everything. And so even severely disabled or intellectually impaired children have the right to go to public school, and the public schools have to provide care for them. Sometimes that means they have to have a one-to-one caregiver, depending on the severity of the disability for this child, but that's really affects the schools. Okay. So I'm still in chapter 54, looking at manifestations. Says the cardinal sign of developmental disorders is delayed achievement of developmental milestones. Again, that's why I showed y'all that sheet that I have that tells you what milestones that they should be attaining or achieving at certain ages. Not that every kid's exactly the same, because there's not, but there is a wide range of ages that they should be rolling over. They should be starting to talk. They should be starting to interact with people and with the environment. So it's those normals that you need to know, so that you can recognize when they do not develop any of these. Then I'm going to go into Down syndrome, and I'm still in maternity, chapter 54, the intellectual disability, when I am looking at Down syndrome. So this is also known as trisomy 21. Again, it is a third copy of chromosomes. I went over this briefly in the previous reproduction lecture. But Down syndrome is a numerical chromosomal abnormality because they have one extra. So maybe they're extra special because they have a third chromosome when it should all be paired in pairs of 2. So look at the etiology. Trisomy 21 is approximately 95% of Down syndrome cases. There are some other cases, but they're not near as common. So for the purpose of this class, I'm focusing on trisomy 21 with Down syndrome. So the incidence of Down syndrome occurring. First off, Down syndrome is the most common genetic cause of intellectual and developmental delay, occurring in 1 out of 733 births. It affects boys more than girls. And here's the main predisposing factor I want you to always keep in mind. Maternal age has been consistently identified as one of the most significant risk factors associated with Down syndrome. Because although it's not unusual in younger women, but let's look at some of these statistics. A 35-year-old woman bearing a child with Down syndrome, she has a 1 in 353 chance. By 40 years of age, she has a 1 in 85 chance of having a Down syndrome baby. And by 45, it's 1 in 35. So age is very much a dominating factor in the incidence of Down syndrome. And again, why is that? I went over that again in reproduction, because the female newborn is born with all the eggs she's ever going to have. We don't make new eggs. We ovulate, we mature and ovulate those eggs every month, but we don't make new ones. Therefore, our eggs age as we do. So the older we get, the older our eggs are, and the more they are likely to have a malformation or a chromosomal issue. So look at your pathophysiology box here about Down syndrome, just so you kind of understand what's going on. They do have certain features and characteristics. You'll see here, they have the slanted almond-shaped eyes, which are the facial features it's talking about, low set ears. A lot of Down syndrome babies have cardiac issues. They also have hypotonic muscle issues. So that means they're just very flaccid. So that's normal for a Down syndrome baby to not have much muscle tone. And let me just give you a little aside on that, and it may be somewhere here. They're more at risk for respiratory disorders, again, because they do have that flaccid muscle tone. We know our diaphragm is the muscle that we need to breathe. And if their diaphragm is just doesn't have much tone, they are not going to breathe deeply, which is going to predispose them to more issues. All right, so your manifestations, look, I want you to read all of that. So, you know, it's identified at birth by the characteristic facial and head features. And just look at what those features are. You need to be able to recognize those. You know, it says a lot of them have vision and hearing difficulties. Hearing loss affects about 75% of these kids. Then it talks about some other body features besides just the facial features. They tend to be very short, have very short hands. They have a single palm crease. You know, if you look at your palm, you probably have those two creases that go along. Down syndrome characteristically just has one. So just look at that. And again, they are at increased risk of some cardiac defects. And then here, this last little paragraph says most children with Downs have mild to moderate intellectual impairment. So a lot of your Down syndrome kids with early intervention can live a pretty normal life. You know, a lot of these kids can participate in work, they can participate in school, they can do their ADLs. And this says most of them. Now, mind you, there are some that are severely disabled that maybe can't even get out of bed. But you see, for the most part, most of them have either mild to moderate intellectual impairment, with the low normal IQ being 70 for people without intellectual disabilities. So that kind of gives you something to gauge this mild to moderate by. Down syndrome kids do have an increased risk of getting an Alzheimer type dementia, usually in their 40s. And I do have a very interesting video under the module section that I want you to look for of a Down syndrome man that is approaching Congress to rally for them, the National Institutes of Health, to do more research on the Down syndrome and Alzheimer's, because Alzheimer's is such a common thing for the older Down syndrome person to have. So they're calling for more research so that hopefully they can prevent that at some point if they can find out what's causing it. All right, so therapeutic management, regular screening, early intervention are essential. There is no cure. If you have it, you have it. You're not ever going to get rid of it. But doing a lot of work with these kids will help them function better in society. Now, this nursing care of the child with Down syndrome in the purple, I do want you to read all of that. I think all of that is important to know. Okay. So while we're still in chapter 54 in maternity, let's look at autism spectrum disorder, or ASD. And if you look here, that it affects two main domains: reciprocal social communications and restricted repetitive patterns. So what does that mean? They can't reciprocate socially. If you say, hey, how are you doing? And most people are going to say, I'm fine. And these kids, they don't understand that give and take of social reciprocity. And the restricted repetitive patterns of behaviors. Now, this is going to be in the more severely affected autistic children, but these are the ones you see that may just bang their heads repetitively, or may just hit their heads, or just do repetitive movements, is what that's talking about. So this is the most common cause of disability in children younger than 5 years of age. The prevalence has increased in recent years, but for a fact, it's because the diagnoses or the diagnostic criteria has expanded, which means that these kids that used to not be diagnosed as autistic, but maybe they were just kind of a little weird. The weird kid that sits by themselves and plays with dinosaurs in school, and doesn't interact. Now those definitions have been expanded, so those kids would now be included in the autism spectrum disorder. It says indicators of ASD are a lack of social ability, lack of verbalization, and this is in young kids when they should be babbling, cooing, gooing. They're not doing that. Little interest in verbal interaction, inability to use toys, lack of smiling. They have an excessive preoccupation with creating order, and they don't respond to verbal interactions well. Parents will often come to you and say things like, they just don't seem to be bonding with me. They don't seek the comfort of their parents like a lot of kids will. Social cues and gestures have little meaning to children with autism spectrum disorders. Again, they're just not socially cognitive. They just cannot understand that give and take that you have to have social interactions with anybody. So if you look here at the prevalence, and we don't know a cause, sorry, the etiology gives you some different theories, but nobody knows for sure what causes this. Prevalence, 1 in 59 children. That's a lot. The boys are affected 4 times as often as girls. Increased incidence in white children. Manifestations. And again, this is where I want you to think these kids need in their mind, in order for them to function at their optimal level, they need a very rigid routine. Everything needs to be the same all the time. So you can imagine, and we're fixing to get into some of this more, but you can imagine as the parent of a kid with one of these more severe autism spectrum disorders, things don't always go like that every day, right? And sometimes you might want to go on vacation. So what happens if you go on vacation with this kid? Totally throws them out of that routine. And they may act up. So there's just a lot that goes along with this. But the manifestations, impairment in communication or language, social skills, and behavior. They may have very astute cognitive or thinking abilities. They may have very high IQs, but not be able to speak. You know, it's just, it's a really odd disorder. Again, the CDC has created a website, Learn the Signs, Act Early. And I want to say again, like I'm telling you all the time, early recognition of common behavioral and developmental signs will lead to early intervention. And the earlier you intervene, the better the outcome is going to be. That's why I keep really honing in on cues. You have to recognize these different cues that these kids are putting off. And one of those is a regression in language or social skills. So a kid has started talking and been verbalizing, and then they become nonverbal. Maybe all they'll do is point. That's a big red flag. It says planning interventions is very difficult, again, because like I said, there's such a wide range of things that may be going on with them. Says a child may have a very large vocabulary, but doesn't understand what those words mean that they're saying. Or a kid may be able to solve really intricate math problems, but not be able to make change out of a dollar bill. So it's just really so individualized per kid. Says in general, children with autism show a fixed, unchanging response to particular stimulus. So again, they have this very almost flat affect because they are not responding back and forth like we are. You see me moving my hands, they're not animated with their gestures. They just don't have that social component. So the child with ASD generally overreacts to any change within the environment. And that's where I was going with, you know, trying to go on vacation or do anything different. They don't have a typical sense of personal space like we do. So they may just walk right up to you and touch you on the face. And, you know, we know that's personally, that's not okay in our environment, but they don't get that. And they could do that even with total strangers, not just people that they know. Socially, I want you to look at those bullet points, but they have a marked lack of awareness of the existence or feelings of others. They don't understand your emotions. If you're crying, they don't understand that you're upset. Lack of abnormal imitation of others' actions. And, you know, this is one of those where when you're playing with these kids and you're looking surprised and then they'll just look surprised, they'll mimic what it is that you're doing or acting like. They don't do that. And they have a gross impairment of any social or peer relationships at all. Now, I've just got to say, after looking at this social stuff, lack of awareness of feelings of others, is that maybe what's going on with all this rise in these multiple fatality shootings that we have, the school shootings, because they all tend to be young males that are doing these shootings. And I would just wonder if maybe some of this has a little something to do with that. Just something to think about. Language, so lack of or very impaired verbal communication. A lot of times they'll have inappropriate volume, pitch, rate, rhythm, or intonation. So they may be speaking very monotone, or they may have echolalia. You say something, they say the same thing right back. So they're just echoing what's being said to them. They're not interacting socially. So the behavioral repertoire here, the stereotyped body movements, and this is what people probably think of when they think of these severely autistic kids. Maybe they're rocking, or maybe they're spinning or banging their head. They're just doing repetitive movements. Marked distress over minor change in the environment. And an unreasonable insistence on carrying out routines. So under your screening and diagnostic evaluation, just again, I'm going to just keep saying it, early diagnoses and intervention prior to the age of 3 years have the greatest impact on improving developmental functioning and reducing symptoms. So early recognition and intervention is key. Therapeutic management. Oh, imagine that. Again, it says early identification of autism is essential. So it talks about some of the things that you would do, creating an environment that facilitates their interaction. Says autistic people have a normal lifespan. They're not like Down syndrome who do tend to die earlier. Caring of the kids with this can be very challenging for their parents or whoever their primary care provider is. They're uncooperative, they're fearful, and they have difficulty communicating. So, if you take them out to eat, just anything out of their routine, they might act up. And it's just something that's you have to be prepared for. Are their parents doing? I mean, you can just see how it's tough. It is tough for their caregivers to try to have a normal life. It says most of them are overweight or obese, or they're at higher risk for that. Sleep disorders. And pica, eating or putting non-food items in their mouth, which we talk about again some with pregnancy, but also these autistic kids tend to have an increased incidence of the pica. These kids have a habit of wandering. They just walk around, not knowing where they're going, not knowing if they're close to home. They're just wandering. So it says traffic accidents and drowning are a common result of that. The main cause of death in these kids are drowning. So parents of these kids have a higher stress level. I mean, just think personally, but also what the book says here. What about that increased cost of care? They're having to go to the doctor a lot more frequently. They're probably on a lot of different medications to try to control different other aspects of this disorder. I mean, I can't imagine the stress level of the parents. We need to educate parents about any resources to assist in the care of their child, because as nurses, that's what we do. We need to know our local resources, and we need to make sure we tell everybody what resources are available to them with these kids. And I want you to read this nursing care, the child with autism. in the purple. I want you to read all of that. And then we will move along to attention deficit disorder. So for this, I want you to go to chapter 53 in maternity. I'm going to start in my book, it's page 1322, but it's just talking about the prevalence of psychosocial disorders of childhood. So it says, unfortunately, the prevalence of mental health disorders in children has increased in the past few decades. Approximately 1 in 5 children are diagnosed with a mental health disorder. And of those, only 1 in 5 are receiving care for that. And if you'll look, attention deficit hyperactivity disorder, ADHD, is the most prevalent current diagnoses, affecting 9.4% of children. That's a whole lot of kids. Again, this is one of those things. There are certain things that they have to show. There are certain criteria that they have to meet in order to have this diagnosis. It talks about boys are more likely to be diagnosed than girls. This one statistic here is going to be important for you later on down the line, that adolescent boys were more likely to die by suicide. And that's going to be important to know if they have the means and they have some type of developmental disability, and they are at increased risk of suicide. And this is going to be the adolescent boy, risk of successful suicide. All right, now I am going to turn to what is in my book, page 1330, and talking about externalizing disorders. So it talks about ADHD, oppositional defiant disorder, and conduct disorder. So ADHD, of course, is what I'm focusing on here. This oppositional defiant disorder, that's rather new. And that is a kid that does not like or does not respond well to authority figures. They don't like to be told no. And so they have come up with a term for this. I call it a bad kid, right? And that's okay. We have a lot of bad kids, and they don't all need a certain diagnosis and to be put on medication. But anyway, that's your oppositional defiant disorder. But ADHD is what I'm going to be focusing on. So look at the clusters of signs and symptoms that you're going to see. Some of these kids, you have all these bullet points up here: impulsive or overly aggressive behavior. And I think impulsivity is probably one of the key factors in ADHD. They just are hyper and they don't think through. They just are impulsive. They're just going to have to do whatever it is they want to do. Harm or threats of harm, stealing, damaging, or destroying property, lying, avoiding school, early smoking, drinking, or drug use, early sexual activity, a lot of tantrums, and consistent hostility towards authority figures. So again, the ADHD, most common disorder that emerges during childhood. And the problems are in 3 areas: attention and concentration. These kids cannot sit in a classroom and be still for an hour. before it's time to take a break or move to another classroom. They just can't concentrate that long. Impulse control, again, that's what I was just talking about, and hyperactivity. Just moving, not ever finishing one thing before they're moving on to the next. It's just all of that combination together. I want to look at the manifestations now. So the diagnosis requires the exhibition of symptoms of this, and you see one is inattention, and it gives you a lot of the different manifestations of that. Not able to complete tasks, not able to pay attention to detail, difficulty attending to work or games. I think I might have that sometimes. In their impulsivity and hyperactivity. They fidget a lot. And if y'all remember, and I guess it's still a thing, but when those fidget spinners came out, this is kind of the demographic that they were looking at. So that these kids would have something that they could do while they're sitting in class. Because they're hyper and it's really tough for them to sit still for that long. It says the signs have to be present for a minimum of 6 months and have occurred before the age of 12 years. Be present in 2 or more settings, which means at home and school, or at school and church, 2 different settings. And impair at least one level of their functioning, academic, social, or occupational. So diagnostic evaluation, again, says the behaviors of ADHD have to be present in 2 of these areas: home, school, or social situations. In social situations, again, you're looking at church, exercise class, just sports, whatever it is they're doing socially. So therapeutic management, you have to have a good balance for that kid. Says they should be able to sit still in school for 40 minutes or handle 1 hour of homework. But that a lot of times has to be modified. A lot of times these kids will need to get up after 15 minutes. A lot of schools now have classrooms where they'll allow these kids to like stand up and even move around while class is going on, which I know is probably distracting to the other kids, but it's helpful for these. So, I mean, there are some creative things that schools have come up with to try to deal with this. But a lot of that is they're just not going to be able to sit still in school, and school age kids is mainly what I'm talking about. And so the therapeutic management I want you to look at in pharmacotherapy is a big one, right? Stimulant medications, which seems like an oxymoron because these kids shouldn't need stimulants. But that is part of their treatment plan. And the ones you've probably heard about are your Ritalin and Adderall and Concerta. So those are pretty advantageous. But look at the most common side effects. Because if anything is a stimulant, it's going to be increasing your metabolism. So you may have weight loss, difficulty sleeping, decreased appetite, and maybe some other motor disorders. So, the medication has to be monitored, and you're really looking for weight loss because kids are constantly growing. And if they start to exhibit a weight loss, that's going to be a problem. Says concerns with increased risk-taking behaviors. Again, unprotected sex could lead to pregnancy, STDs. or things that you have to be watching for with these kids. And again, you have to teach the parents what they need to be looking at. And I do want you to read this nursing care box in purple, the child with attention deficit hyperactivity disorder. I want you to read that. Okay, so while we're still in the maternity book, under human development, I still have to go over menopause, and we're going to go over aging. I'm going to do menopause first, but then our aging is going to be coming out of our med-surg book. So turn to chapter 32 in your maternity book. And in mine, it's page 708. And it talks about menopause. So the term just simply means the end of menstruation. No more periods, no more monthly bleeding. Menopause, if you'll look, is 1 year without any menstrual activity at all. That's the definition of menopause. You have to be 1 year without any periods for you to definitely be considered or diagnosed with a menopause. Menopause is a normal part of aging. We all do it, women. So the age at menopause is approximately, which means it's around 45 to 50 years of age. Now, are there a lot of different things that can affect that? Of course there are, but that is your average age at menopause. So what are some of the physiologic changes that are going on? So your ovaries, who've been producing that estrogen and progesterone every month in order to prepare that egg follicle, they start decreasing their hormonal functioning. Says when those estrogen levels decline, the organs of reproduction undergo regression. Different things happen. A lot of times with that decrease in estrogen, everything atrophies. So, I mean, the vagina, the uterus, all the reproductive organs just tend to atrophy a little bit. Even the breast lose a lot of that fatty tissue and atrophy. As the vaginal tissue loses the lubrication and is easily traumatized. Dyspareunia. Anyway, that just is talking about discomfort during sex. Happens because of that loss of elasticity. It says, in addition, absence of the estrogen, so in other words, that hormone that's not being released, is associated with bad changes in your lipid levels. The LDLs, your low density lipoproteins, low is bad. So that increases. So your bad cholesterol increases, and your high cholesterol, high is good, your good cholesterol decreases. So you're at increased risk of cardiovascular disease and a lot of other things that come along with that hyper or high cholesterol. It talks about hot flashes, characterized by a sudden feeling of heat or burning of the skin, then perspiration. It says they occur more commonly at night. And then you have a lot of interrupted sleep. So you can just kind of see where a lot of this stuff just compounds upon itself to kind of make this time in your life miserable. But again, some women have a lot of issues with menopause physiologically, And others, they just like don't have their period and may have some of the atrophy, but they don't have a lot of the other issues that come along with it. It says some symptoms do not have any physiologic explanation, like depression, mood swings, irritability, and agitation. Says one of the most puzzling aspects of menopause is the wide variation in symptoms. Again, like I said, some women may not have anything except maybe some hot flashes and no period, whereas others may have a host of all these other issues that go along with it. So there are some different therapies for menopause. Of course, again, it's not a disease, so you're not going to cure it. This is a normal part of the aging process. But hormone replacement therapy is something that in the past the physicians did. They would, of course, give them synthetic estrogen and progesterone hormones to replace the hormones that now their body is not producing. Along with that, and you'll see here as greater research results emerged, they found that estrogen has, there are some estrogen dependent cancers, and so it can put certain women at increased risk of cancers. And you just have to look at some of the women that may or may not qualify for this. And the decision regarding hormone therapy is very complex. The woman really needs to talk about that with a doctor because they need to go into the history, into the lifestyle, and a lot of different things. It says some women do not qualify, such as those who had breast cancer or clotting disorders. If they smoke, again, lifestyle, have diabetes, heart disease, or any liver disease, renal, those are often contraindications, again, for hormone therapy. So hormone replacement therapy isn't the be-all, end-all. And there are a lot of over-the-counter herbal, complementary, and alternative medicine therapies that women will use to help with these menopause symptoms. This gives you some things. If menopause hormone therapy is contraindicated or not chosen, here's some other measures the women can do to help promote their comfort. Using water-soluble lubricants, KY jelly, not Vaseline, no petroleum-based. To help with the painful sex. And again, talks about the botanical preparations, in other words, your herbal therapies. Doing Kegel exercises. You can never go wrong teaching the woman to do the Kegel exercises. I'm drinking a lot of water, and always make sure, and I know you think everybody knows this, but they do not. Women have to wipe from front to the back anytime they go to the bathroom. They cannot wipe from back to the front. And you would be surprised at how many people don't know that, which is why I always say they need to know that. That's just one of the teaching things you always need to have in your mind, is how they need to wipe. Kegel exercises, when you're teaching them how to do the Kegel exercises, for those of you that may not know, here's how I was taught. So it's the muscles that you use to stop your flow of urine from the bladder. So just think whenever you're peeing, just stop and get a good grasp of what those muscles are. And then you want to, when you're doing the exercises, act like you're on an elevator and you're stopping on the first, second, third, fourth floor. And then you're going back down and releasing like that. So that's the exercises. You stop, 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 right? Or constrict, however you want to put it. So just the elevator connotation always stuck with me because I thought that was a good representation of how to do those Kegel exercises. All right, so osteoporosis, we have to talk about that with menopause because postmenopausal osteoporosis is very common. And you see here, especially in small bone, fair-skinned white women and Asian women. Even though it's a risk for all women after menopause, it tends to hit those two demographics the most. The bone loss really begins well before menopause, but that decreased estrogen, again, at menopause, it accelerates the bone loss and slows the bone regeneration. So not only are we losing it at a faster amount, our bodies aren't regenerating the bone as quickly as they used to. So it's kind of a double whammy there. Talks about osteoporosis is reduced bone density, leaving the bones porous, fragile, and susceptible to fractures. And they do have pretty common bone density tests that they can do at physicians' offices, and a lot of times they will do that with postmenopausal women. The vertebrae and hips are the most common site of fractures because this, of course, is going to increase your susceptibility to a fracture or a break if you do fall or have an accident. Predisposing, again, I talked about the demographics. Other risk factors could be women who started their period late or had early menopause, a sedentary lifestyle, women that smoke, drink alcohol, or do excessive amounts of caffeine have an increased risk. Drugs, corticosteroids, some anticonvulsants that may be used for epilepsy would increase your risk. An inadequate lifetime intake of calcium or vitamin D is a risk factor. And you need vitamin D in order for the calcium to be absorbed into the bones. And here's one of the theories I have on that. How do we get vitamin D? Of course, you can take your vitamin D pill, but you can also get it from the sun, which is where most people have probably always gotten their vitamin D from. The sun converts into vitamin D into your skin. But anyways, what do we do now that we're so worried about skin cancer? Especially these pale little white women. They're going to have sunscreen, sunblock to where they're not getting that sun, or they're just going to be covered up in clothes and hats. So, is our desire to avoid skin cancer leading to an increased chance of osteoporosis? I don't know, but just something to think about. Manifestations. If you turn the page, look at this. Actually, these women will start having a decrease in their height, and it's because the vertebrae are kind of folded in on each other at this point. So they lose their height, and then they'll develop that dowager's hump, which I'm sure you've seen out in public, and there's this picture of it here in figure 32.4. Kind of what goes on with the progression of osteoporosis. So prevention. So the major goal of treatment is prevention, or slowing it to stabilize whatever bone mass is remaining. There are a lot of good drug therapies now that you can take for this. And it has those in a lot of these bullet points here. Fosamax is one that you see used a lot. Calcium and vitamin D supplements. I still say it's always best to get it from the source. It's best to get it from your milk or a little bit of sun exposure, but you can take supplements. You know, and again, what goes on, especially once you get in a nursing home, how much sunlight do any of those older people get? Hardly none. So you have to think about the whole process that's going on when you're looking at this. And exercise. This is one of the easiest, most free things that we can teach these women to do. Weight bearing and resistance exercises have been shown to increase bone density and build muscle mass. It gives you some examples of what it means by weight bearing exercise. You're talking about walking, hiking, dancing, the resistance, use of free weights or weight machines. At least 30 minutes a day of this exercise is needed to help prevent osteoporosis from becoming worse. So 30 minutes a day of a weight-bearing exercise. Now, is swimming a weight-bearing exercise? No, swimming is not, because you're weightless in the water. So weight-bearing means walking, something that's going to be putting weight on your extremities. So nursing considerations here are going to be counseling women about lifestyle factors. If they smoke, we want to counsel them to quit smoking, quit drinking, no excessive caffeine intake. How about fall prevention? Because nurses are always concerned about safety. So fall prevention is big. You know, talk to them about how their home looks. Do they have small pets that may run under their feet? Rugs that don't have backing that could slip. There's just so many safety things to help prevent falls that you have to look at. Adequate lighting. And then it gives you just a variety of nursing issues that could be relevant. Decreased activity levels, chronic pain, altered body image, and decreased ability for self-care. Those are some of the things that we would be looking at as nurses. But you can't go wrong with telling them to walk 30 minutes a day. All right, and then some pelvic floor dysfunction that comes along with menopause as well. I want to start here with just the uterine prolapse. It says those ligaments that support that uterus. A lot of times during pregnancy, they're stretched and they never return quite to normal after childbirth. So it says as they stretch, the uterus sags backward and downward and into the vagina. And you'll see this in nursing homes. I see this almost 1 to 2 little old ladies in each nursing home has uterine prolapse into the vagina. Symptoms of this. Pelvic fullness, pelvic pressure, fatigue. It just feels like something's coming out down there. In therapeutic management of this, of course, it's going to depend on their age, their physical condition, sexual activity, and how bad the prolapse is. Surgical procedures provide the most satisfactory therapy. And a lot of this is what you may have heard called a vaginal tack. They're tacking the bladder up. But it says treatment for severe prolapse may include a vaginal hysterectomy. That is when they go in and through the vagina, they can go in and remove that uterus down through the vagina. That way they don't have any open abdominal incisions. If for some reason they can't have surgery, you may also have heard of a pessary. So a pessary is a device that supports pelvic structures. It has to be inserted into the vagina. Of course, the ideal is for the women to be able to insert this themselves and take care of it themselves. It says it has to be inspected and changed as needed by a physician or a nurse practitioner. Teaching the woman to insert the pessary and remove it nightly. will reduce discharge, and they may have an estrogen vaginal cream that they will be prescribed to go along with that, or potentially oral estrogen. So nursing considerations, again, here are going to be those Kegel exercises. Can't go wrong with those pelvic floor Kegel exercises. And I just want to look at urinary incontinence for a second, because that is a thing. Stress incontinence is going to be a big problem with women post-menopause, especially if they have had children. And stress incontinence, that is that urine leakage. If you sneeze, cough, laugh real hard, if you pick something up that's real heavy and you really kind of overdo it, just some urine escaping, and that is your stress incontinence. That's the main one I'm looking at here with this menopause. All right, so that's going to be it for menopause. What I'm going to do now is get this Med-Surg book out. And we're going to look at aging. So chapter 5 is the chapter that deals with chronic illness in older adults. And what I'm looking at here is, if you'll turn the page, it's on my page 66. I don't know what page of yours it's on, but where it starts with older adults and demographics of aging. So you have a young old adult and an old adult. So you're looking at the young old 65 to 74 years of age, and the old 85 and older. So what does that do to 75 to 84? I guess those are the middle old adult. It doesn't say. But let's look at some attitudes that we may have towards aging. It's going to depend a lot of times on how these people present themselves to you. Are they old and comatose in a bed? Do they have dementia? Are they very vigorous and playing sports? So a lot of the attitudes towards aging that you have to do with what you are around and what you know to be true about older adults. One of the things before I even get started, even in nursing homes, if these older adults are not all with it, I always want you to remember their tremendous value. You know, they may have been World War II pilots. They may have been doctors, lawyers. They may have been farmers that raised food. They have had so much value that it's just a tragedy sometimes, I think, in the way I see them being treated, especially in the long-term care facilities. And I just always want you to remember the tremendous value that our older generation has. Okay, so myths and stereotypes about aging. You know, it says a lot of time this is supported by the media or the commercials or the way people portray older adults as being very negative and kind of hostile and ornery, I guess is one of the words that we use for older people. May think that they're rigid in their thinking. If you have any of those preconceived notions or ideas, you may not give them some of the newer evidence-based things, because you're going to think, oh, they'll never do that because they're just so rigid in their thinking. So you need to be very aware of your attitude itself on aging and ageism, to make sure you're not discriminating or being biased about any of this. All right, so We have our biologic aging. That reflects the changes that occur over time. This is something that your body is just going to wear out. And some of your processes, peristalsis, some of those processes are going to be more slow and slower as you get older. The way you metabolize medication is going to be a little different. That's biology. I like this figure 5.2 here. The biologic aging can be a balance between negative and positive factors. So, look at those two weights with aging in the middle. I like how that looks. Says research is directed at increasing older adults' average lifespan. We're always trying to help people live longer. But we also want them to have a good quality of life and continue to be functional. Because what's the point in living to be 110 years old if for the last 20 years you're, just laying in bed with very little quality of life. Physiologic changes. These are the normal changes that occur from age as well. And then I want to look at cognitively impaired older adults. So one of the main things I want you to take away from this is most healthy older adults have no noticeable decline in cognitive abilities. That means it is not a normal process of aging to have a decline in your thinking processes. Now, they may be a little slower to tell you what's going on, but that doesn't mean that they are dumber or have a decline in their ability to think. They just might be a little slower formulating their words to give you that information. It does say that they may have a mild decline in memory, but that does not mean it's a cognitive impairment. It goes on to talk about some rural older adults that may have barriers to healthcare access, homeless older adults. But the main thing I want to see here is the demographics of aging, the attitudes, especially being aware of your attitude that you have towards the aging population. And to understand that it is not a normal process of aging to lose your mind or to lose any cognitive function. All right, to finish off our human development concept, I want you to go back to your maternity book in chapter 6. This is where, I have given you that extra resource about developmental milestones. The book has a shorter, I think more concise chart about it. So it just talks about knowledge regarding developmental milestones, helps caregivers to determine whether the baby is growing and maturing as expected. Growing means, are they gaining weight? Are they getting taller? Maturing is talking about their psychosocial aspects and cognitive aspects. We need to remember, again, like I said, these developmental milestones are for the average. Your normal infants will vary a little bit. Everybody doesn't have to do the same thing at the same time. But then turn the page and look at your table 6.1, a summary of growth and development in the infant. And, you can see physically what motor skills they should have. Under your psychosocial and sensory, psychosocial, I want you to put Erikson around that because again, I'm a big fan of Erikson's psychosocial theory. And Piaget is going to be your sensory cognitive theorist that a lot of the books align with. But I want you to really look over this table 6.1, kind of get a good grasp of what kids should be doing at certain times. These are their developmental milestones. Along with that, if you turn the page I'm at 89, psychosocial development. So again, that's Erikson's. It says an infant has to, their job is to develop a sense of trust versus a sense of mistrust. How they do that is if the caregiver is meeting their needs, then they will develop that sense of trust. You know, if they're being fed when they're hungry, if they're being changed when they're dirty, if they're being held when they just need comfort. It's those basic things that help them to start to develop that sense of trust. And of course, mistrust is going to be that their needs are not taken care of, so they cannot develop that sense of trust. And then I want you to turn a few pages. Actually, we're going to go to chapter 7. And I want you to look at the different types of play that kids engage in. Because this again is very telling about their growth. So infants and toddlers, and I'm on page 115 here, do they participate in parallel play? What that means is they may be sitting side by side, playing with a car, playing with a doll, playing with whatever they're playing with, but they're not playing with each other. They're just playing beside each other. And that's what parallel play means. And another thing I want you to understand is play for children is very important. It is the work of kids. Through play is how they learn how the world works. It's where they develop their motor skills. They learn that a round peg won't fit in a square hole. You know, they learn all this by play. So play is very serious business for kids. They need to be allowed to experiment with play as much as possible. Then turn the page and looking over here at psychosexual. No, actually, I'm not there yet. Let's look at play. When they get older, when they get to their preschool years, which is 3 to 5, they participate in associative play. This is a cooperative type play. They are learning to share. They're not so egocentric now that they just think everything belongs to them. They can cooperate with each other and play with each other. So this is an important time for them. And imaginary friends are common around 3 years of age, sometimes 3 to 6-ish. That's pretty common. And then the psychosexual development. And I'm just going to go ahead and hit this real quick here because we are about to go into a new concept of sexuality. Says sexual identity and body image are developing as this child. Sexual curiosity and exploration is normal. They want to know, how come a boy has a penis and a girl don't? There's just a lot of different things they don't know and they need to know. But it says parents greatly influence their children's sexual development. Again, positive interactions is going to be a lot better than any negative interaction. And it says they imitate masculine and feminine behaviors in play, and gender identity is well established by 6 years of age. And that's what we are about to get into when we start our sexuality concept.